Welcome to Chapter 14, Nursing Management of Patients with Coronary Vascular Disorders. Coronary atherosclerosis is the most common cause of cardiovascular disease in the United States. Atherosclerosis is an abnormal accumulation of lipid or fatty substances and fibrous tissue in the arterial blood vessels. Basic processes occur in atherosclerosis and include overgrowth of intimal smooth muscle cells with accumulation of macrophages, white blood cells, and T cells, and accumulation of lipids, especially cholesterol, in the connective tissue. These processes narrow the vessel lumen and restrict blood flow to the myocardium. This may be adequate when the client's at rest, but not when the client is engaging in activity. This results in cardiac ischemia, which typically results in angina and chest pain. The following slide depicts coronary atherosclerosis, and the anatomic structure of the coronary arteries make them particularly susceptible to the mechanisms of atherosclerosis is because they are not basically smooth. Risk factors for coronary atherosclerosis include non-modifiable risk factors such as age, gender, race, or family history, and modifiable risk factors such as diabetes, hypertension, smoking, obesity, physical inactivity, and elevated cholesterol. Question: the nurse caring for a patient who had a recent MI, the nurse is aware that the plaque that likely contributed to this event is mostly made up of. Answer: lipids. Clinical manifestations of atherosclerosis include ischemia, which is an inadequate blood supply that deprives the cardiac muscle cells of the oxygen needed for their survival, and angina pectoris, or chest pain, that is brought about by myocardial ischemia. Classic signs and symptoms of myocardial ischemia include an acute onset of chest pain, shortness of breath, extreme fatigue, diaphoresis, and nausea and vomiting. Prevention of and medical and nursing management of elevated cholesterol levels include controlling the cholesterol levels, diet, exercise, medication, smoking cessation, manage hypertension to an acceptable level of less than 120/80, and managing tight control of diabetes with blood sugars less than 80. Angina. Angina is a temporary imbalance between the coronary artery's ability to supply O2 and the cardiac muscle's demand for oxygen. It's almost always associated with a significant obstruction of a major coronary artery. Anginal pain can have a wide variety of symptoms. There are two main types of angina, and they include stable and unstable angina. Stable angina is chest discomfort that occurs with moderate to prolonged exertion in a familiar pattern to the patient. Stable angina is usually relieved with nitro arrest. Long-term treatment for stable angina includes calcium channel blockers such as cardizem and/or beta blockers such as sotalol. Unstable chest pain or discomfort occurs at rest and with minimal exertion, and it causes marked limitation of activity. An increase in the number of attacks and an increase in the intensity of the pain characterizes unstable angina. Pain may last longer than 15 minutes, and it's poorly relieved by nitro arrest. Treatment for unstable angina includes oxygen and reperfusion procedures such as percutaneous coronary interventions, stents, and CABG. A newer way to describe unstable angina and MIs are acute coronary syndromes. In these syndromes, it is believed that the atherosclerotic plaque in the coronary artery ruptures, resulting in platelet aggregation, thrombus formation, and vasoconstriction of the coronary arteries. MIs are also classified as STEMI, which is ST segment elevation MIs, and non-STEMI, which are non-ST segment elevation MIs. Diagnosis is usually made by history, EKG, and cardiac biomarker analysis such as CKMB and troponin T. Question: when discussing angina pectoris secondary to atherosclerotic disease with a patient, the patient asks why she experiences chest pain with exertion. The nurse informs the patient that exertion A. increases the heart's oxygen demands. Management of coronary artery disease and management of angina include nitrates, such as nitroglycerin. Nitroglycerin can be given oral, sublingual, spray, and IV infusion. Beta blockers, calcium channel blockers, antiplatelet medications and anticoagulants, oxygen administration, thrombolytics, and percutaneous coronary interventions such as stents, percutaneous transluminal coronary angioplasty, and coronary artery bypass graft, or CABG. Myocardial infarction, or MI. The pathophysiology, risk factors, and manifestations of MI are similar to those of angina. Often, it occurs when myocardial tissue is severely deprived of oxygen. Possible causes of an MI are rupture of the atherosclerotic plaque with occlusion of coronary artery by a thrombus, a coronary artery spasm, which is a sudden constriction or narrowing, and decreased oxygen supply, such as found in blood loss, anemia, and hypotension, and increased demand for oxygen, rapid heart rate, cocaine, and thyroid toxosis. When blood flow is reduced by 80–90%, ischemia develops in the heart. Ischemia can lead to necrosis of myocardial tissue if blood flow is not reestablished or restored. Infarction evolves over a period of several hours, which is why timely diagnosis and treatment is crucial in MIs. Diagnosis and categorization of MIs are based on EKG changes and analysis of cardiac biomarkers such as CK-MB, myoglobin, and troponins. EKG analysis results in diagnosis of unstable angina, non-STEMI, and STEMI MIs. This slide depicts the myocardial infarction activity with the depiction of the EKG changes that happen in the subsequent problems. In a zone of ischemia, you'll note that there's T-wave inversion on the monitor. When there's a zone of injury, you'll note that there's ST segment elevation. And when there's zone of necrosis, you'll note that there's an abnormal Q wave on the EKG. This will be further discussed in our class. MI symptoms include pain. Chest pain in a classic presentation is left-sided, radiating down the left arm, and it's usually associated with activity. It is important to note that males often present with a typical pain pattern, whereas females have a more abnormal pattern, such as pain down the opposite shoulder and up into the back and neck. Pain can be right-sided, radiating into the jaw, the back, the shoulders. It can be numbness, tingling. It can be described as an elephant sitting on my chest and a pressure rather than a pain. Pain at rest or waking a patient up from a dead sleep is associated with poor outcome, and the most common time for an MI to happen is at 5 a.m. Rest will often relieve the pain. Other symptoms of MIs include shortness of breath, where the patient feels like they can't catch their breath. This is more commonly associated with congestive heart failure. Nausea, many patients describe it as a heartburn or queasy feeling, and some may even have episodes of vomiting. Diaphoresis, patient may be sweaty, may say they broke out in a cold sweat, may appear pale, cool, and clammy, and a high level of anxiety. Patient will present with some degree of anxiety. They are uncomfortable, miserable, and they usually know something is not right. Diagnosing an MI, initially an EKG monitor, apply a cardiac monitor right away. A 12-lead EKG is also crucial. Vital signs immediately, as these can be tip-offs to many problems with your patient. A thorough assessment, history, and physical assessment, including all medications. Lab, troponin T, CK-MB, electrolytes, calcium, magnesium, complete blood count, coagulation studies. Cardiac markers. Troponin T elevates a little bit later, but stays elevated longer. CK-MB elevates quicker, but falls within 3 days. Myoglobin, if a patient comes in quickly, will show up earliest of all the cardiac markers. ABGs, or arterial blood gases, may or may not be performed depending on whether or not the patient may be a candidate for thrombolytics. 12-lead EKG, looking for ST segment elevation in leads other than lead 2. And ST segment elevation in specific leads at the 12-lead are indicative of acute myocardial infarction. Again, it is important to note that sometimes you'll have a patient presentation without the typical lab work elevations, but they will still have ST segment elevation on their 12-lead EKG. This just means you're catching the patient in the early stages of the infarction before there is enzyme climb into the systemic circulation. The following slide depicts a patient who has an inferior MI, and you'll note the ST segment elevation in the circled areas in lead 2, lead 3, and lead AVF of the 12-lead EKG. Management of an acute MI includes medications such as aspirin, nitro, morphine, beta blockers, ACE inhibitors, and statins. Morphine is given for pain that's unrelieved by nitro. It has afterload reduction, pain relief, and anti-anxiety properties, and it also relaxes bronchioles to enhance oxygenation of the patient. Oxygen is started immediately, especially if the O2 sat is less than 94%. You want to optimize coronary perfusion. Nitroglycerin is given for chest pain and afterload reduction. Nitro is a specific coronary vasodilator, and it also improves collateral blood flow. It dilates the coronary arteries, thereby improving blood flow, thereby reducing myocardial ischemia. Aspirin decreases platelet aggregation at the site of the clot and is often indicated. Remember, it's important to note that aspirin can be chewed, and the normal dose of aspirin is 81 milligrams to 325 and is care provider dependent. Also remember that if you're going to give aspirin in the acute phase of an acute MI, that it is not appropriate to give any type of enteric-coated aspirin, as it will take too long to dissolve into the system. Nursing care for an acute MI focuses on relieving pain, promoting respiratory function, promoting tissue perfusion, reducing anxiety, and monitoring the patient for complications. Other helpful therapies in an acute MI include beta blockers, which slow cardiac conduction, thereby increasing cardiac filling time of the ventricles, which reduces myocardial workload. ACE medications, or ARBs, are within 24 hours. ACE inhibitors block the renin-angiotensin system to decrease blood pressure, promote sodium and fluid excretion for a slight diuresis, and decrease oxygen demand of the heart. Remember that it's important to manage lab work imbalances and replace potassium if needed and magnesium if needed to prevent any further cardiac dysrhythmias. Remember the saying SAAB, S-A-A-B, which stands for statin, ACE or ARB, aspirin, and beta blocker. Cardiac rehabilitation is important, and reperfusion therapy must be established. Again, management of patients with acute MI may include thrombolytics. Thrombolytics include alteplase or TPA, inactivase, or retaplase, RPA or TNCase. Thrombolytics are the big guns of acute coronary care. They're drugs which actually dissolve and lyse the clot that is present in the coronary artery. They're indicated for chest pain longer than 20 minutes, but less than 6 hours from onset of pain. Some centers have actually drawn out the time period to 12 hours with not too bad of results. Remember, with your thrombolytics, you must administer within 30 minutes from the time the patient arrives in the ER, and you must monitor the patient very closely for any signs of bleeding in other places, such as GI bleeding, intracranial bleeding, or other types of bleeding. New studies out are suggesting that emergent angioplasty is more effective and has better outcomes for management of acute MI. However, the problem is that many rural Americans do not have access to this type of service in a timely fashion. Therefore, thrombolytics are still an important part of acute MI management. Percutaneous coronary interventions, or PCIs, are another crucial intervention for acute MI. And remember, time from the patient's arrival to the ER to the PCI is critical, as time is muscle. Percutaneous transluminal coronary angioplasty, or PTCA, is an invasive but technically non-surgical technique, whereas a balloon-tipped catheter is introduced through a guide wire to open blocked coronary vessels. The balloon itself is then inflated and occludes the occlusion by compressing the plaque against the vessel wall. This procedure is best used on clients with single or double vessel disease with proximal, non-calcified lesions. Heparin and nitro are used during the procedure to prevent clotting and vasospasm. Glycoprotein inhibitors, such as Plavix, are prescribed for many of these patients to prevent restenosis. Restenosis is a problem in many patients and most often occurs within the first 30 days post-procedure. Stents are round plastic devices that are inserted into the opening after the angioplasty to prevent reocclusion and maintain patency of the stenosed artery. This next slide depicts percutaneous coronary intervention and shows how the balloon-tipped catheter is inserted into the artery, it's then inflated, and the plaque is pressed against the vessel wall. The second slide off to the right actually shows stent placement. The stent is actually put onto the balloon, and the balloon is inflated into the artery and then deflated, and the balloon pulled out, and the stent sits in the artery and keeps the artery open. Post-op care of patients with PCI include complications such as acute closure of the vessel, bleeding from the insertion site, reaction to the dye used, hypotension, hypokalemia, and dysrhythmias. Anytime you open up a stenosed artery, there's going to be improved blood flow to the cardiac muscle, and oftentimes this is irritable to the heart in the first early phases of the procedure. So you might see some what's called reperfusion arrhythmias develop, and this is common. Reperfusion dysrhythmias are handled by ACLS protocol with drugs and other therapies as needed. Nursing care of the patient post-PCI include activity restrictions, IV fluids to promote IV contrast excretion, monitor the insertion site of, which is usually the femoral artery, for pulses, bleeding, and hematoma from the site. Post-procedure at-home drug therapy is going to include nitrates such as nitroglycerin, calcium channel blockers, aspirin, beta blockers, ACE inhibitors, glycoprotein inhibitors such as Plavix, and Coumadin for at least 3 months post-procedure with a stent. Most of the time, all of these medications or a combination of thereof, depending on what other medications the patient is on, will be used for the patient for at-home drug therapy. Question: is the following statement true or false? A patient who has undergone a PCI has had one or more coronary vessels replaced with new patent vessels. The answer is false. During PCI, an occluded coronary artery is opened and reperfused by a balloon catheter. Surgical procedures, CABG. Coronary artery bypass graft, or CABG, is a long-standing surgical procedure in which the blood vessel is grafted to the occluded coronary artery so that blood can flow beyond the occlusion. Indications for a CABG include angina uncontrolled with meds or PCI, treatment of left main coronary artery stenosis, prevention or treatment of acute MI, arrhythmias, heart failure, and treatment that was unsuccessful with percutaneous coronary interventions. The qualification criteria for a CABG include coronary arteries that are 70% occluded or 60% occlusion of the left main coronary artery. Pre-op care for the CABG patient includes preparation and teaching, which is vital, as some clients have to wait 1 to 6 weeks for a procedure. Medications will need to be adjusted, and make sure the patient is aware of this. Return demonstrations of turn, cough, and deep breathe, splinting, and arm and leg exercises are important. The nurse teaches the patient to report any pain to the nurse and ensures the patient that pain medication will be available. It is critical to teach and use the pain scale in these patients. Review any chest and leg incisions, chest tubes, Foley catheter insertion, and IV catheters. And remember now that some patients do not have a leg insertion, as oftentimes now a vein in the arm is being used. So they may have either or, and prepare them for that. Remember, it's important to remind the patient that they'll have pacer wires coming out of the mediastinal sternal area. They might have an endotracheal tube and a ventilator, and provide as much information as possible to the patient in order to help with coping of the pre-op procedure. This picture here depicts a slide showing the internal mammary artery graft from the left subclavian artery down into the left main coronary artery. And the other one shows a saphenous graftage where the blockage is at in the right coronary artery. This is a 2-vessel CABG as noted here. This next slide depicts the cardiopulmonary bypass system. A U-shaped tube is inserted into the superior and vena cava respectively, and as blood flows back into the heart, the blood from the superior and inferior vena cava is routed into a venous reservoir where it's filtered, and then it flows into an oxygenator and heat exchanger, through the pump, back through a filter and bubble trap, where then it's rerouted into the subclavian artery where it can go out into the systemic circulation. Nursing process, the postoperative cardiac surgery patient. Initial post-op care of the patient with a CABG focuses on hemodynamic stability and recovery from general anesthesia. These patients always have a Swan-Ganz catheter in, and the pulmonary artery systolic and diastolic, central venous pressure, and the pulmonary artery wedge pressures are monitored carefully in these types of patients. Later care focuses on the monitoring of cardiopulmonary status, pain management, wound care, progressive activity, and nutrition. Frequent multisystemic assessment is imperative in these patients, and monitoring for complications is crucial. Table 14.4, page 410 of Pellico, has the complications that are important to be monitored in these patients. Complications for cardiac surgery include MI, hemorrhage, and dysrhythmias. One of the other less common complications of cardiac surgery, but one that bears mentioning, is post-pericardotomy syndrome. Post-pericardotomy syndrome is an inflammation of the pericardial sac thought to be associated with excess blood that remains in it post-bypass. The patient experiences chest pain and discomfort, a pericardial friction rub on auscultation, dysrhythmias, an elevated temperature, and an elevated white count. For most patients, the condition is mild, and for few, treatment is similar to that to treatment for pericarditis is necessary. And so in these patients who develop this type of syndrome, if it's mild, it's not treated. If it's a little more severe, they may be started on some nonsteroidal anti-inflammatories. If it's very severe, it may be Toradol IV, and others, it may be an oral nonsteroidal anti-inflammatory. Postoperative care of the CABG patient also includes mechanical ventilation for 3 to 6 hours or as long as necessary post-op. Early intubation is critical in these patients, and patients will be intubated as soon as possible, and they'll actually be up and walking as soon as possible also. Years ago, these patients used to be kept quiet and on the ventilator for anywhere from 24 to 48 hours. That does not happen anymore, as these patients are often extubated within the first 3 to 6 hours, and they're dangled within the first 3 to 6 and hopefully up walking as soon as possible. Mediastinal tubes, chest tubes, to water seal drainage are accomplished so that the patient's chest has the opportunity to drain. Connect epicardial pacing wires to the pacer generator. And remember, because the patient has a Swan-Ganz catheter in, putting the pacemaker, a temporary pacemaker in, is not an option. That is why epicardial pacing wires are used. And also the epicardial pacing wires are directly on the heart and much more effective than a temporary pacer would be. Additionally, the patient will have a Swan-Ganz catheter, and so it's critical to perform Swan readings, monitor their vital signs and cardiac rhythm, monitor their invasive lines, they'll have an arterial line, and monitor their lab work, calcium, magnesium, phosphorus, potassium, hemoglobin and hematocrit, white blood cell count, BUN and creatinine to assess their kidney function. You're going to monitor these patients' IV infusions, and they may be on multiple IV infusions, depending on their vital signs, their Swan readings, their lab work, or the patient condition. Initially, post-op, it's critical to manage hypothermia in these patients, as these patients often come back very cold because they've been on the bypass machine. A warming blanket might be indicated in these patients and is most often used in the post-op period. You want to manage their hypertension. Hypertension puts pressure on the newly grafted vessels, and so it's important to make sure that nitroglycerin and niprite are both being used to keep their blood pressure under strict control. Initially, too, you want to manage bleeding. You're going to measure their mediastinal drainage and their chest tube output hourly. You report any drainage that's greater than 150 cc's an hour to the medical doctor. Initially, too, with their chest tubes, you may do what's called an autotransfusion, where the mediastinal drainage that's collected in the chest tube reservoir is heparinized and retransfused back into the patient. And also with their chest tubes, it's important to not let the tubes loop over the bed for adequate drainage. Monitor these patients and manage cardiac tamponade and keep their mediastinal tubes patent, and that's the best prevention. Monitoring their level of consciousness is critical, as these patients could have an associated stroke during surgery. And last but not least, make sure you're managing their pain. It is absolutely vital to not be stingy with these patients with their pain medication, as they need to be able to move, and to move they must have their pain effectively controlled. This next slide here I'll let you review on your own, but it shows all the different types of tubes that may be in your patient and how you're going to assess those. Nursing interventions in the postoperative cardiac surgery patient include restoring cardiac output, maintaining adequate tissue perfusion, maintaining their body temperature at an acceptable level, preventing infection of both any of the drain sites and their surgical incision, preventing fluid and electrolyte imbalances, preventing impaired gas exchange, and promoting cerebral circulation and pain control. So as you can see, nursing diagnoses in these patients include cardiac output, tissue perfusion, infection, gas exchange, and pain control. Psychosocial issues with these patients help the patient to cope with the changes that may happen in his and her life and assess their ability to effectively deal with them. Assess the client's understanding of the disease process and use a calm and reassuring approach. This is not the time to lecture and judge on their lifestyle, but it's time to offer appropriate solutions to some of their problems that they deal with. Provide acceptance and help identify information and resources that might help the patient. Provide factual information about their diagnosis, about their treatment, and about their prognosis. And foster constructive outlets for their depression, anger, and hostility, and identify previous coping methods that may have helped for the patient. Question. The nurse caring for a patient with an MI knows that the top priority in the care of this patient is what? Balancing myocardial oxygen supply with myocardial oxygen demand. Critical complications of acute MI. The client who experiences an MI is expected to regain hemodynamic stability, evidenced by the following: blood pressure and pulse within the client's acceptable range, adequate urine output, adequate mental alertness, clear lungs on auscultation, and palpable peripheral pulses. Two of the biggest complications of acute MI are heart failure and cardiogenic shock. They can occur separately or together, and they require intensive medical management as their prognosis can be poor when happening. Complications of acute MI include heart failure, which is common after an MI, a decrease in cardiac output as a result of left ventricular dysfunction, septal rupture, papillary muscle rupture, valve dysfunction, or right ventricular infarction. Along with heart failure, cardiogenic shock can ensue, and the most severe form of heart failure accounts for most hospital deaths after an MI. In cardiogenic shock, the nurse monitors the patient for the following signs of poor organ perfusion that may result from decreased cardiac output: a change in their orientation or mental status, urine output less than 33 cc's an hour, cool, clammy extremities with decreased or absent pulses, unusual fatigue, or recurrent chest pain. Cardiogenic shock occurs when decreased cardiac output leads to inadequate tissue perfusion and initiation of the shock syndrome. Causes include MI, end-stage heart failure, cardiac tamponade, pulmonary embolism, cardiomyopathy, and arrhythmias. The pathophysiology of cardiogenic shock is that the heart muscle loses contractile power due to direct damage. You get a decrease in cardiac output and a decreased oxygen supply. Cardiogenic shock signs and symptoms include cerebral hypoxia, hypotension, rapid and weak pulse, cold and clammy, tachypnea, crackles in the lungs, and decreased urine output less than 30 cc's an hour. Management of cardiogenic shock includes hemodynamic monitoring with a swan to adequately assess the amount of shock. The pulmonary artery wedge pressure is evaluated and the central venous pressure is evaluated. Lactic acid levels to determine whether or not your patient is going into metabolic acidosis. Correct the underlying problem, such as percutaneous coronary intervention. Treat the MI, treat the dysrhythmias, and mechanical intubation. Another management of cardiogenic shock may be medications such as vasopressors. One of the common ones that is used is either dopamine, epinephrine, or Levophed. Dobutamine is often not indicated in cardiogenic shock because the amount of contractility increase with dobutamine will increase cardiac oxygen demand. Therefore, vasopressors are another important treatment in cardiogenic shock as they help to raise the blood pressure and sometimes improve cardiac output. We will talk more about vasopressor therapy in cardiogenic shock in our class.